Hope you have a very delicious Sobhumi lunch. And so I am here to welcome you back on an exciting academic session to keep away your postprandial sleepiness. Myself, Dr. Saurabh Bhomik, I am here for the next 30 minutes with you to give you different insights of the management of autoimmunity. In this session, we shall check how we can arrange our armamentarium to control the Mirzafar, as like Brutus, as said by Dr. Shushruth Sen. It is always difficult to identify and kill the traitor. That requires a meticulous planning and delicate execution of that. So let's identify who are the main role players in this game. For this session, we have Professor Alokendu Ghosh, sir. Sir needs no introduction actually. Sir is the HOD of Department of Immunology and Rheumatology of IPG-MER Kolkata. Sir, please come on stage. Dr. Upal Sengupta, the renowned nephrologist of the city. He is a senior consultant nephrologist of Fortis Hospital and Kidney Institute of Kolkata. Dr. Bashov Bijay Sarkar, senior consultant internal medicine of Fortis Hospital, Kolkata. Bashov, please come on stage. Dr. Bhaskar Narayan Chaudhuri, sir is a senior microbiologist and infection control officer of Peerless Hospital, Kolkata. Sir will come a bit late. Dr. Sanghita Chatterjee, madam is the senior consultant histopathologist of Medica Super Specialty Hospital, Kolkata. Madam, please come on stage. And Dr. Rajoshi Sarkar, consultant biochemist of Dr. Roy and Trivedi Diagnostic Center, Kolkata. Rajoshida, please come. For this session, we will go through on a quiz-based pattern so that it becomes easier to identify the role of the individual players in the management of the autoimmunity. So let's start our first case of the session. This was a 36-year male, had a family history of rheumatoid arthritis, complained of a low back pain for last 3 to 4 months with lower limb radiation and headache for 2 weeks. On general investigation, his CBC is almost okay. Total protein LFT is also okay. Other biochemical parameters are normal. CT brain was done. That was found in the normal limit. Only thing in the mild sacroiliitis was revealed in the MRI spine and pelvis. HLA-B27 was done. That came as a normal. And this patient was managed by the local orthopedician, and he responded on analgesic and physiotherapy. That patient again came back after 6 months with a complaint of periumbilical dull-lacking pain and with some extent of alteration of bowel habits. Endoscopy was performed. On upper GI endoscopy, mild hiatus hernia was there. And on colonoscopy, there found multiple small ulcers like skip lesions with induration within 30 centimeters of the terminal ileum. Biopsy was done and sent for the histopathological examination and also for the TB-PCR to rule out tuberculosis. TB-PCR came out to be negative. On CT scan, there was some kind of luminal stricture in the rectosigmoid and also in the terminal ileal segment with conglomerated lymph nodes around the ileocecal region. So the radiologist suggested that the possibilities include the Crohn's disease and tuberculous stricture. So let's look at the biopsy first. So I will request Dr. Sanghita madam What we are seeing, ma'am?
So this is the endoscopic biopsy showing colonic mucosal beads. This is the ulceration, I can't point out. The mucosa is ulcerated and it shows ulcer exudates. There is a subulcer granulation tissue.
Right.
And about the architecture of the crypts, there is a distortion of the crypts in the form of crypt branching. Next photograph. Next. There is crypt branching and also there is paucity of crypts. That is, density of crypts are
The crypt loss are there.
are less. And about the inflammatory infiltrate, there is dense lymphoplasmacytic infiltration in the lamina propria. There is another photograph. You will find the crypt abscesses just before that. There is a crypt abscess and also the neutrophilic cryptitis. And next, there is a basal plasmacytosis and you can see a superficial
Some epithelar
granuloma.
histiocytes are also there in the subepithelial plane.
There's
Some
a
vague collection
granuloma.
like microgranuloma sort of
So
pattern.
the concentration of findings favor inflammatory bowel disease.
Right.
But whether to sign out as Crohn's, I'll correlate with the endoscopic findings where you can see the longitudinal ulcers and the skip
Skip
lesions.
lesions were there.
And the TB-PCR is also negative, so I'll sign out as Crohn's colitis,
Okay.
Crohn's disease.
Okay, ma'am. Can we differentiate to some extent with the tuberculosis, which was another
It has
differential
been-
diagnosis in this
Yeah,
case?
it has been a challenging situation.
Though I know it's a very difficult to differentiate morphologically.
Both of these lesions show granulomatous inflammation, but in tubercular colitis, you find large granulomas with giant cells, and if you
Right,
can
right.
demonstrate AFB in the next picture,
Yeah.
so you can.
If we get the AB, then
yeah,
it's
you can say
a gold
that's a
standard for
tubercular,
diagnosis of TB.
Yeah.
Yeah, thank you, ma'am. So I will come to Rajoshida. Whether there any role of biochemical parameters to differentiate between these two entities?
Indeed, intestinal TB has been always been called the great mimicker.
Right.
It mimics closely with many diseases, most closely with Crohn's disease, right from the signs and symptoms up to the colonoscopic findings. For a definitive diagnosis, we go for the gold standard, that is TB culture or AFB stain. The specificity is around 100%, but it falters in the sensitivity part with only 20 to 40% of sensitivity, mostly because of inadequate sampling and also because of the paucibacillary nature of the disease itself. So herein lies the importance of some inflammatory markers which can be assessed in the peripheral blood itself. The first one which comes to my mind is the T-cell mediated interferon gamma release assay, IGRA, which is commercially famous as the TB Gold or quantiferon.
TB Gold.
So there have been studies going on, studies consistently showing that both sensitivity and specificity is in the range of 70 to 90%. So herein the sensitivity increases almost double to that of TB cultures. And also IGRA is very useful in diagnosing, in monitoring the severity of the disease also. For TB, intestinal TB, with a cutoff of about 400 picogram per ml, you get the very classical features of severe weight loss, etc. The second marker which comes to my mind is
Can we
what
please
is
have silence? Thank you.
what is known as the Forkhead box P3, also abbreviated as FOXP3. It is an upregulator of CD4, CD25 positive T regulatory cells. So this combo test, it has got very good discriminatory power between Crohn's disease and intestinal TB. So if my memory serves me right, the cutoff of about 32.37% is what the literature says, above which is intestinal TB and below which is Crohn's disease.
Right.
And then one more immunological marker that is important is CD73.
Okay.
Where CD73 we measure in the pathological biopsy specimens, specifically the mesenchymal stem cells in the biopsy specimens. And we were discussing about the PCR. PCR is negative in this instance, but there are certain improvements in the methods. For example, multiplex PCR. In contrast to simple PCR, multiplex PCR simultaneously amplifies 2 or more targets, thereby increasing the sensitivity of the assay.
Accuracy also.
Yes, so these are some of the markers which came to my mind, which may be important in distinguishing between the two.
Right. Thank you, Rajshida. Many of these markers are also not known to us. And now we come to Dr. Bhaskar Narayan Chaudhuri, sir. So, whether there are any microbiological investigations to differentiate TB and CD, and if you can give some insight about the ASCA and ENCA for diagnosis of Crohn's disease.
Okay. Actually, you have discussed, I will ask everyone to maintain silence, please. We are getting distracted because of the commotion there. So, for microbiological investigations, we have talked about PCR. PCR is definitely now the gold standard, but actually the gold standard is culture.
Right.
So even if you send PCR, you send a sample for culture also, the same sample for AFB culture and AFB staining.
But it
Okay,
takes time.
AFB staining has got a very low sensitivity. PCR will detect in GeneXpert Ultra, we are now detected up to 13 bacilli per ml if it is a paucibacillary case. But in culture, we are detecting up to 10 or less bacteria per ml if the culture and the sampling is very important, which already Rajoshi has pointed out. The sample, if the sample is wrong, then we are getting a wrong diagnosis. We are not getting the diagnosis, actual diagnosis. But for CD, I think for CD there is no microbiological investigations as such. But for differentiating, we have got these biomarkers, that is ANCA. ANCA is, that is P-ANCA, which is actually MPO negative P-ANCA due to other antigens, autoantibodies antibodies against other antigens. So that is a hallmark of diagnosis of ulcerative colitis. So in 80% cases of ulcerative colitis, the P-ANCA is positive. But one important differentiating feature is the ASCA. So if ASCA is positive, and in around 7% of the CD cases, P-ANCA will be positive. But if we go for ASCA, then it's a hallmark of Crohn's disease.
Right.
So ASCA is better for that.
Okay. Thank you, sir. So there is a twist. The patient again come after 6 months with complaint of dry mouth, metallic taste, and polyarthralgia. So, Bashwada, what should we do next?
Saurabh, thank you. It's really a good case because I particularly like that mentioning of family history of rheumatoid arthritis.
Right.
So, since our theme is autoimmunity, so Saurabh has tried to give us hint in every step. So far you have heard about the discussion. It's definitely going in favor of Crohn's. And Crohn's, basically, it's also a dysregulation of the immune system, the intestine, because it's an abnormal immune response to whether the commensal bugs or the pathogenic organisms with a genetic susceptibility and the environmental factors, though we don't know the exact cause till now, but these are the probable causes. So it is also a dysfunction of the immune system. So
Exactly.
definitely a patient having family history of some autoimmune disease will have higher chance of developing this. Now my question is, what did the patient receive for these 6 months? Which treatment did the patient receive? Because you have diagnosed, he definitely must have received some treatment.
Yeah.
So what was the treatment for these 6 months?
For these 6 months, the patient was treated with the steroids and other treatment for the Crohn's disease, actually. He
What?
was,
Steroid, anti-TNF alpha,
Mesalazine was there,
infliximab.
possibly so.
So patient received steroid.
Yeah.
Now steroid for how long? That is also very important. You see, what happened in these 6 months, that is very important. I am coming to your question. Definitely if a patient develops dry mouth, polyarthralgia, you have to search for other autoimmune diseases, as you know. So we can go for ANA for polyarthralgia, definitely anti-dsDNA, and also the intestinal diseases which can lead to extraintestinal manifestation like celiac disease. So you can go for anti-TTG, okay? So tissue transglutaminase. So again, you can go for Sjogren's also. So because dry mouth,
Dry mouth was
polyarthralgia. So you can go for anti-Rho, anti-La, all this. But I think that should be mentioned, that what happened to the patient in these 6 months. So was the patient maintaining fine these 6 months? Was he absolutely fine? And how long steroid was continued? And whether he again developed any oral ulcer also?
No,
We don't know.
oral ulcer was not
And if
there.
the steroid was prolonged beyond 8 weeks, did he have any adverse effect from that? So
Okay,
this is important, I think. Okay?
Okay.
Just we are jumping after 6 months, but what happened in these 6
Oh,
months?
yeah.
So next line of investigation, definitely I would like to go for other autoimmune markers, because the autoimmune diseases which can lead to polyarthralgia and dry mouth, as I have mentioned, I think these things should be done.
Yeah.
So
So
We should go for
ANA
that.
was done actually in this case.
Yeah.
This is the
ANA HEP2 should be done,
HEP2
obviously.
ANA
Indirect
picture is
immunofluorescence
there,
assay.
right.
Yeah.
HEP2 ANA picture is
Now
there.
it's done with HEP 2010, so it's an improvised version of HEP2. So this ANA picture, it's a, I think, anti-centromere antibody pattern. There are, although there are not many nuclear dots over here, there will be numerous nuclear dots ranging from 42 to 92, 94 or something like that. But there are condensed chromosomes which also have the dots. So I will go in favor of anti-centromere antibody pattern by looking at this ANA.
Right, sir. It was reported as AC910, ANA HEP2 positive.
So that is anti-centromere.
And the ANA profile was done, and that gives the
This
centromere.
AC910, this is the pattern. No?
This is a pattern.
So,
This is a pattern.
no, what is it signifying in this case?
So this
No.
is CB actually, anti-centromere antibody. So actually we go for
In
9,
case
10,
of
they are the numbers given to the different
specific pattern has
patterns.
been designated with specific
nuclear-
numbers, and for some patterns, some kind of antibodies can be positive. So
Yes, yes, this is
gives some kind of
anti-centromere
hint that
antibody.
this antibody might be positive. That has to be looked
So next,
after by
the
the
ANA
immunoblot.
profile is being done. So ANA profile centromere antibody is positive. So this is, and RO52 recombinant is actually, it's weakly positive. So it goes in favor of primary biliary cholangitis, earlier known as primary biliary cirrhosis. So that is the diagnostic of that.
Yeah, okay. And sir, what is the reporting protocol in these cases? Actually, I just want to know from the microbiologist point of view, for reporting of the ANA profile and F2ANA, what should be the protocol and that is
Reporting
actually-
protocol, first we go for ANA. If ANA is positive and showing a specific pattern, then we go for ANA profile. So
To confirm
ANA
the
profile,
specific-
where there are actually 18 autoantibodies which can be detected by ANA profile. So there are many other autoantibodies. So ANA strongly positive, but we are not finding any autoantibody on ANA profile. We have to go for other specific antibody.
Right,
But here we are getting something. So that is the protocol that we are following.
right, sir.
As a clinician, can we ask that what should we advise, ANA HEP2 or ANA profile? As a clinician, I want to know.
That will be my next
No,
question.
that first ANA,
I will ask Bashar.
go for ANA first. If ANA is positive, then you go for ANA profiling to identify the specific autoantibodies.
Actually, ANA,
Can I add something?
right, sir.
In this interesting issues, when ANA is negative, one can have Rho and La positivity even in the setting of Sjogren syndrome. And ANA positivity with Rho and La positivity is there. And for Rho, we can have either 52 or 60 positivity. And centromere, as is being depicted here, is a pointer to look, or clinician, as a clinician, as we are talking, to look or exclude for scleroderma. So whether Raynaud's
Right.
phenomenon was there or not in the patient, that's an important issue if this is there. So for clinician, when clinical suspicion of connective tissue diseases are there, one certainly look for ANA and ANA positivity with profile, or ANA negativity also can demand ANA profile when we are strongly suspecting CTD in the form of Sjogren's, where we can get negative ANA with a positive Rho and La. I think
Right.
this is the clinical connotations one should keep in our mind.
Sir, I am just continuing this question to you. So considering the picture so far, can we give any specific diagnosis in this case?
Yes, the important clinical issues would be when a patient is having a Crohn's disease with morphologic picture in CT with a histologic suggestion, and when one definitely have excluded tuberculosis, so certainly in the setting of female patient with arthralgias, the standard clinical dictum is when a patient is having clinical inflammatory arthritis, oblique and or arthralgia, with rheumatoid factor positivity but not rheumatoid arthritis, with ANA positivity but not systemic lupus, one certainly should think for Sjogren's, which is very common in our clinical setting. So when a patient is having ANA positivity with Rho positive and centromere positive, with a clinical hints for arthritis and Sitka syndromes, so this certainly brings in our mind to diagnose it at Sjogren's, and we have classification criteria of Sjogren's, and that demands not only this component, but certainly Sharma and minor lip biopsies, which can give the scoring for definite diagnosis. So in this setting, one should not forget to bring Sjogren's as a differential or primary diagnosis, and once autoantibody is supporting, it gives a very important clue.
Right. Sir. Thank you, sir. And sir, how to manage? It's your question.
Yes, keeping this Sjogren's as a possibility, and as internist Dr. Bashok Vijay Shaka was asking, what was the treatment given? If in between patient was being treated with corticosteroid, with immunosuppressions, certainly in that setting, if Sjogren's develop, it's a very important issue. Then certainly it demands more aggressive immunosuppression. Otherwise, patient should have responded or not have expressed this type of clinical phenomenon, where Sjogren's again is coming in the setting of while patient is on immunosuppression. Otherwise, in a classical Sjogren's syndrome, we give hydroxychloroquine as a primary therapy. That's more than enough. But Sjogren's nowadays are coming to us as a neurologic manifestations or even nephrologic manifestations. These two are very important issues which we are getting. So for primary therapy, hydroxychloroquine will be enough for initiating therapy in primary Sjogren's syndrome. I mean, it's nowadays is not Sjogren's syndrome. It's called primary Sjogren's disease because it's not only restricted as a syndrome, it encompasses multi-organ manifestations.
Multi-system
Sir, in your
disorder.
practice, are you giving azathioprine with infliximab?
Where?
In these Crohn's?
Crohn's, yeah. Azathioprine with infliximab. No, I mean, for Crohn's, certainly corticosteroid with sulfasalazine, mesalazine.
Yeah.
Not responding, methotrexate, azathioprine can be tried. Not responding, then one should go for infliximab.
Thank you, sir. Bashod, whether the initial presentation of headache and low back pain has any relation with the present disease status?
This is a very good and tricky question, I think. So actually, you see, the headache might be of absolutely any other pathology, but if we go by your single pathology approach, so if you search the literature, you will see that these Crohn's disease patients, they might have higher incidence of headaches compared to non-Crohn's disease persons. Because, studies have shown that most commonly this is a tension type headache, but some studies have shown that migraine is also of higher incidence here, though most of the studies are showing that migraine is of equal incidence. So definitely there is evidence that headache in Crohn's disease patients is more than other population who are not having Crohn's. Now in this case, it might be a completely different cause of headache. But if we try to correlate, because we should always have that single pathology approach.
Right.
So this low back pain due to sacroiliitis, Crohn's disease with extra intestinal manifestation, headache, that also can occur due to this. So might be the primary process started actually, which was diagnosed much later.
Crohn's might be diagnosed
Might
later.
be, might.
Right.
Might.
Upalda, can there be any...
Before that, I cannot control my temptation to address the low back pain issues where already MRI done, where HLA-B27 done. I mean, the important issues in reference to the clinician is low back pain with a diagnosis of inflammatory low back pain, with a diagnosis of ankylosing spondylitis is 0.6% in the population. It's very rare. And low back pain, when it is being defined as inflammatory low back pain, that is more than 6 weeks duration, more than 45 years, I mean less than 45 years, and more at night, throughout the day, no pain. Certainly primary investigation is not MRI, not HLA-B27, but X-ray. X-ray documenting sacroiliitis with a classic inflammatory back pain defines the diagnosis of ankylosing spondylitis. For ankylosing spondylitis, one should not go for MRI. And second part, HLA-B27 is rarely being asked for the diagnosis of ankylosing spondylitis. So inflammatory back pain, until and unless it is classically inflammatory, and until and unless there is X-ray documenting no sacroiliitis, so by definition it is not ankylosing spondylitis, but non-radiographic spondyloarthritis. There only one can go for MRI, because interestingly, in NEJM, a decade back there was an interesting article, pivotal article came up. They have tried MRI in a normal young medicos, and they have documented pathological, quote unquote, pathologically degenerative joint disease. And everybody was absolutely normal. So they have concluded that the advice of MRI would be very misleading. You will get degenerative joint disease in a normal, degenerative joint disease in a back pain. You cannot identify whether it is causal or casual. So for back pain, one should be very meticulous where to demand MRI, X-ray or HLA-B27 before planning for diagnosis. Yes, sorry.
Thank you, sir, for the insight. Upalda, any renal complication can be anticipated in this case?
So if we consider only Crohn's disease, there are actually increased number of extra-intestinal renal manifestation of Crohn's disease. One of them is a few of them are associations, like number of glomerulonephritis. We know that IgA nephropathy is far more, has increased number of incidents in Crohn's disease and ulcerative colitis. Other than that, secondary membranous nephropathy and membranous proliferative glomerulonephritis are also seen as a glomerular disease. Tubulointerstitial nephritis, in the biopsy series in inflammatory bowel disease, chronic tubulointerstitial nephritis was one of the most common finding in kidney biopsy. Other than this, a pathological cause-effect relationship is hyperoxaluria in Crohn's disease and ulcerative colitis, especially where there is an ileocolic disease, and especially after surgery where there is increased enteral hyperoxaluria and there is formation of stones. There is much increased incidence of nephrolithiasis, especially oxalic acid stone in Crohn's disease and ulcerative colitis. Talking about the Sjogren syndrome, we, as sir said, Sjogren syndrome patients present to us in a typical electrolyte disturbance, mainly as pseudo-Bartter and Gitelman syndrome. Gitelman and Bartter phenotype presenting in adults. On investigation, they came out to be as autoimmune, mainly Sjogren syndrome, antibodies acting against the renal tubules.
That means patient should be keep on continuous follow-up to look whether any renal complication is developing or not.
Exactly, yeah.
Right. And there is only last finding in this case, very interesting. On follow-up, after 1 year, the routine HRCT was done for this patient to some other causes, but that find out that there is some small lymphoidal conglomeration in the anterior mediastinum just behind the sternum. And so on suspicion, PET CT scan was also done, and that gives very low metabolically active component. So can the mediastinal lesion be any kind of thymic hyperplasia, sir? Professor Ghosh?
As a clinician, we always feel very jittery with random investigations like this one, because this patient is having a Crohn's. This patient came up with Sjogren's, then certainly FDG PET coming up with some quote-unquote thymic hyperplasia. Yes.
No, why was it advised at all?
No, he told
because the patient was very anxious, actually, literally seeing.
That's why
So-
PET CT, FDG PET CT.
No, PET CT was done after seeing the lymphoidal conglomeration in the anterior mediastinum. He just thought in her mind he has developed some kind of lymphoma or so. And so he was very apprehensive and insisted clinicians, please go for the PET scan, and it was found.
Now, in CT scan, you have described patient has got a more lymph nodes there in the abdomen as well.
Right, sir.
So there was in abdomen already documented to have lymph
Yes,
nodes.
yes, yes.
They can have, they are afraid of lymphoma. For that reason, they have done that one. But certainly, lymph node histology would be an ideal situation if lymph nodes were accessible.
Exactly.
Otherwise, an intestinal thymic hyperplasia at the age of 36,
36 male.
is not a very common one, and it should not be a physiologic but reactive hyperplasia. And how common to have thymic hyperplasia in autoimmunity background? Certainly, very commonly we see in myasthenia gravis.
Yeah.
And for rheumatoid arthritis, systemic lupus is very rare. So that's it, because for the thymus, the T cell, autoreactive T cells, these are being deleted as a negative selection, and the rest of the T cells were being targeted. So they stimulate through this AIER, and that can have an immune axis. But again, this is not clinically relevant in reference to our common rheumatological, immune-mediated disease like lupus or Sjogren's, or even mixed connective tissue diseases like that one. So for follow-up, certainly for this mediastinal quote-unquote thymus oblique lymph nodes, one certainly can have either HS-CT thorax or abdominal ultrasound or CT to have documentation of enlargement of lymph nodes if they are or not. And that can give us access, if that is accessible, histopathology will solve the solution.
Right, sir, right. Okay, so we are closing this case so far and go to the next case. We have to be a bit hurry. And this was a 22 years female presented with oral ulcer and photosensitivity malar rash with arthalgia for last 3 to 4 months. Fever was for 2 weeks. On investigation in CBC, there was a low hemoglobin of 9.6. Other two lineages are normal. ESR was a bit high. TSH, prolactin, glucose were normal. Fever parameters are also normal. No infectious cause identified. In urine, there was protein 3+, blood 3+, plenty of RBCs and pus cells. Granular cast was there. On culture was negative. Urine ACR was high. Urea creatinine normal. And in LFT, total protein normal with altered albumin globulin ratio. So, Bashoda, what can be the possibility and what next?
Since we are
investigation should
running
we do?
short of time,
Yes.
just one possibility will come, that is SLE. If you go to the previous slide, please go to the previous slide.
Because
So the
malar
typical
rash,
clinical
so
features,
classical malar
oral
rash.
ulcer, photosensitivity, malar rash, arthralgia. Next, and fever also. You see, hemoglobin is low, though there are other cell lineage are okay. ESR high. And here you can see pyuria, hematuria, and proteinuria. Classical. And you see this globulin high AG ratio altered systemic inflammation.
Right.
Yeah, that is a cause. And definitely, if we have to go for one test, that will be ANA first.
Right.
First,
ANA
we have
was
to go for
done,
ANA.
and
So
this is
if
the
ANA
picture.
positive, then we'll proceed. If ANA negative, then we'll think otherwise.
ANA was positive and it was a homogeneous pattern. And also in ANA profile, HEV2 positive, dsDNA positive, SMD1 positive, RNP rho positive.
So anti-dsDNA positive, it comes in diagnosis of, and also this anti-Smith antibody is also positive. So these are hallmark of SLE. So there is no doubt that this is a case of SLE.
Okay, right. So I am not going to the details of the clinical criteria. This is a case of SLE. So now, what is the role of biochemical parameters in diagnosis of SLE? Dr. Rajushi.
Hello. So as it is well known that SLE starts as an autoimmune immune complex disease, but then progresses as an inflammatory phenomenon,
Right.
acute on chronic inflammatory phenomenon. So it can be easily surmised that the diagnostic tests are based on the immune complex phenomenon, while for monitoring the disease activity, we mainly depend upon inflammatory markers. So it is in the realm of inflammatory markers that biomarkers come into play. The first inflammatory marker which is very commonly used is the ESR, mainly because of its affordability. The ESR is very high generally in active SLE. This very high ESR is caused due to three interrelated phenomena. One is hypoalbuminemia. The second is polyclonal hypergamma-globulinemia, and the third is decreased RBCs due to an anemia of chronic disease. Because of this interplay of three phenomena, it is very difficult what causes the rise in the ESR.
Yes.
So the next marker that we usually use is the CRP. Now, CRP alone may be ambiguous, but in relation to ESR, in active SLE, what we see is what is known as the ESR-CRP dissociation. It is akin to the albuminocytological dissociation we find in some CSF studies. What happens here is the ESR is very high, in the range of say 100, but the CRP is only mildly raised, rarely above 60 mg per liter. So when this happens, it is almost diagnostic of acute phase of SLE. When you get a CRP more than say 150, it would definitely seem that the active disease of SLE has a concomitant infection. So monitoring of SLE with CRP is important to distinguish between active SLE and active SLE with infection. The role of procalcitonin mirrors that of CRP with an important distinction that procalcitonin distinguishes very well between SLE pleuritis and SLE pleuritis with infection. Because procalcitonin is generally normal in SLE pleuritis in the former, but with infection it rises. Whereas CRP is raised in both the level, both the conditions. Now, this consumptive hypocomplementemia, this is a very hallmark of SLE. So much so that C3 and C4 are routinely measured. So far, so good. But one small thing we need to keep in mind that complement system forms the border between autoimmunity and inflammation. So complement markers can also be used as acute phase reactants. This is actually what happens when in the very beginning of the acute phase of SLE, exacerbation of SLE, we see the C3, C4 levels go up because of the acute phase reaction. It gradually comes down when the process lingers on. So lastly, I would like to touch upon some emerging markers which may have a very bright future in near future. One of them is the alarmins. Alarmins are proteins which are elaborated by the neutrophils and macrophages. They are recognized by the TLR4, toll-like receptor type 4. One of the putative molecules is known as S100A2, which has the very high discriminatory power between the healthy and those with SLE, and also between those with quiescent SLE and with those with active SLE. So this is one marker which I would say has a very great future. The next markers are obviously the cytokines. For SLE, type 1 interferons are important. But as we all know, interferons are very dicey to measure them because of their lability and because of their other circadian variations, etc. So what is done here is actually the surrogate markers are measured. For example, for IL-18 binding protein is measured.
Okay.
For TNF, soluble TNF receptor type 2, these are measured. And last but not the least are the chemokines, which occur in the downstream as in the cascade after cytokines. So all these inflammation markers are, I think, important in this issue.
Thank you, Rajshida. So Upalda, would you recommend kidney biopsy for this patient? Definitely, possibly yes. And what are the indications?
So if you see the first biopsy, the slide, the presenting slide, it's written on the face that the patient is having a glomerulonephritis. It's ACR report is more than 2000 A3 category of proteinuria with what we known as active sediments or what we have learned as telescopic sediments in SLE.
Yeah.
Telescopic sediments mean if you use a long distance lens of somebody using, you can see every component of urine in a single sediment. That is the SLE's classical urine sediment is known as telescopic sediment that is present in over here, and it's an indication of the biopsy. In general, even if the urine is far less angry, if the proteinuria is just more than 500, then also there is an indication of the biopsy. If the urine sediment is normal, the patient is having a deteriorating renal function for unexplained etiology, then again it's an indication of the biopsy.
Right. Thank you. So biopsy was done, and this is a picture. Madam, what you are seeing?
In this patient, there was active urinary sediments and active lupus serology. So a kidney biopsy will show a proliferative lesion. As you can see here, there is a global endocapillary hypercellularity, and on the right-hand side, there are hyaline thrombi and also a wide loop lesion. So it belongs to class 4 or class 3, depending on the number of glomeruli sampled. If it is more than 50%, then it will be diffuse or class 4, and if it is less than 50%, it will be class 3.
Right.
So here there are crescents and fibrinoid necrosis.
Yes.
So it is a class 4, likely a class 4
Yeah.
lupus.
So it was class
Active
4.
lesion.
Class 4 lupus nephritis was there, and the DI
And
was
this-
also done.
Yes, it is a full house positive.
Full house positivity. Right. So what are the classifications of lupus nephritis, ma'am?
Yeah, classification of lupus nephritis is through ISN and RPS classification 2004 into 6 classes. So class 1 is mesangial, minimal mesangial lupus nephritis, where we get a normal histology of glomerulus on light microscopic examination, but on IF you'll find immune deposits in the this is class 2, where you find mesangial hypercellularity
Right.
and mesangial deposits on IF. Coming to the third, this is the class 3.